Thanks you all for being here in the Senate Finance Committee. Today is Thursday, March 14th. It is our last hearing day for Senate bills. I apologize for our late time, but we were 4.5 hours on the floor and had a little bit of time to eat lunch. So thank you all for being here. Thank you for your patience. I'm going to read the bill order. First bill is Senator Feldman, who's here, Senate Bill 1009, then 1059, 1071, 957, 1018, 1020, 1060. So that's our bill hearings for today. We're going to ask that the sponsor has as much time as they need, but the witnesses have 2 minutes. Please honor that because we have to vote and go back on the floor again. So it's a long day for us. So Senator Feldman, do you want to bring up your panel?
Yes, and let me bring up Andrew Garrison, who's going to be here just for information purposes only. Dr. Andrew Koop, who's the Associate Dean of Academic Affairs at the University of Maryland School of Pharmacy, and Timothy Hamilton. And let me try to get some goodwill from the get-go. Madam Chair, as you know, about 6 or 7 panelists signed up on this panel and additional witnesses. So we've pared it down from 6 panelists to 2. And I think, and this also, I'll make the point that this bill did pass in this form, 136-1 just yesterday from Delegate Pam Gazzoni. And it's a task force bill. So with that said, let me just get right to it on Senate Bill 1009. And right off the bat, I have to say, some of you may look at the bill and you're going to see the name psychedelic substances, and many of you might immediately tune out. And similar to 10 years ago when I was here on the topic of medical cannabis came up, and it was a similar kind of thing, like, what the heck? What are we thinking? What are we doing? And of course, now we've got 40 states in the United States that have legal medical cannabis. So if the 136-1 House vote yesterday did not force you to keep an open mind, let me give you a few additional points to make that case. So this is actually an area that's been studied far more than cannabis, whether for behavioral health issues related to post-traumatic stress disorder, addiction, broader behavioral health depression issues, addiction, chronic pain. Just another tool in the toolbox when you're dealing with treatments. A few years ago, actually, Senator Elfreth sponsored a bill that passed unanimously out of the legislature to create a state fund to provide cost-free access to psychedelics for military veterans suffering from PTSD and traumatic brain injury. Many of you may not know this, but right now, the Johns Hopkins has a center for psychedelic and consciousness research. It's leading the way in the United States in innovative treatments using, again, psychedelics. So the task force that's the subject of this bill will be staffed by the Medical Cannabis Administration. We've got Mr. Garrison here. They've had obviously a lot of experience over the years with the development of the medical cannabis program. So now that I hope you have an open mind about the task force bill, just a few additional things. Right now, we have studies taking place right here in Maryland at our research institutions at Johns Hopkins, NIH, at the federal level. And the research includes clinical trials for depression, again, addiction, PTSD, and end-of-life mood disorders. Just 9 months ago, the FDA published new draft guidance to highlight fundamental considerations for researchers investigating the use of psychedelic drugs for potential treatment of medical conditions, again, including psychiatric or substance use disorders. This is the first time that the FDA has provided that kind of guidance to the industry when industry is designing clinical trials for psychedelic drugs. Treatments using psychedelic substances are expected to be approved for certain treatment-resistant PTSDs by the FDA by the end of 2024. And finally, let me just say there are currently 8 states in the United States with task forces just like this one on the topic: Alaska, Connecticut, Hawaii, Minnesota, Nevada, Texas, Vermont, and Washington. So what SB 1009 does, it establishes a task force to study and make recommendations to the General Assembly on the use of psychedelics. A lot of lessons have been learned. The Medical Cannabis Administration, again, as I said, has agreed to staff the task force, learning from drawing some of the lessons they learned on medical cannabis. The task force will consist of a variety of stakeholders, experts to review existing laws, policies, and practices related to the use of psychedelic substances using scientific data. You'll be hearing from a couple of the experts right now on the panel. The task force will report back to the General Assembly by July 31st, 2025. There's a lot of support in your folder, including the Maryland Department of Health, Mental Health Association of Maryland, and others. There's one amendment, Madam Chair, that's clarifying. The bill as introduced includes a representative of a federally recognized Native American tribe, but there actually are no federally recognized Native American tribes in Maryland. So the amendment simply strikes federally recognized and the phraseology in the state. And as I mentioned earlier, this bill with those amendments passed yesterday, the House of Delegates 136-1. And for all those reasons, Madam Chair, I'd ask for a favorable report on Senate Bill 1009. Thank you, Madam Chair.
Senator, I just want to be clear. So you're happy with the amendments on the House bill?
Yes, I mean, I would urge the body to, or the committee to just pass the bill as it passed out 136-1, the House of Delegates. I know it's late, and if it turns out you have to work out off the House bill, that's fine too. But if you find a way to get it to the floor sooner, that'd be fine too. So
Thank you, Senator.
yeah, and my panel is here, but I'll certainly answer any questions if there are some now.
Thank you, Madam Chair and Senators. Good afternoon. My name is Andy Coop, and I hold a PhD from the University of Bristol in the UK. I'm Associate Dean for Graduate Programs at the University of Maryland School of Pharmacy, and I oversee 6 courses in our Masters in Medical Cannabis program, including a course on medical psychedelics. I support SB 1009. Psychedelics are substances that affect mood, perception, and cognition, and this task force will focus on psilocybin and psilocin from mushrooms, mescaline from cacti, and DMT, dimethyltryptamine, from plants. Much research has been performed on psychedelics, especially at institutions in Maryland. The psychedelic substances named in this bill have all shown to be beneficial in a treatment of a wide range of health conditions, including PTSD, depression, abuse, and also the treatment of chronic pain, OCD, anxiety, eating disorders, and traumatic brain injury. There are clinical trials funded by the NIH. The FDA has designated psilocybin a breakthrough therapy. The Department of Defense is funding psychedelic research for veterans. This shows the support of the federal government and the safety profile. A search has shown there are 54 clinical trials currently going on in Maryland, and again, with a safety profile almost unheard of, including no overdose, no withdrawal, no hangover, and no addiction. Scientists have shown that the effects of psychedelics are almost certainly due to something called neurogenesis and neuroplasticity. I'm going to explain what those are very quickly. After activating the brain's serotonin system, the serotonin system is the same system that actually works in depression. The actual neurogenesis and neuroplasticity builds new connections and actually grows new neurons in the brain.
Andrew?
Good afternoon. My name is Tim Hamilton. 4 years ago, I sat alone at the kitchen table in the early hours of the morning, decided to take my life. Had my young son not stumbled into the kitchen at that exact moment to get a drink of water, I wouldn't be here today. So what brought me to that point? Like 8% of the country's population, I have clinical depression. For 10 years, I battled nonstop suicidal thoughts every waking moment of the day. I tried everything to break free of the thoughts: counseling, exercise, changed my diet, meditated, journaled, even did TMS shock therapy. Nothing helped. Then I turned to medication, but not only were the side effects horrible, but it didn't even work particularly well. Then I read Michael Pollan's book, How to Change Your Mind, which was on the New York Times bestseller list. It was about the new science of psychedelics, specifically psilocybin mushrooms, and how they were completely upending every aspect of mental health. And all types of top-notch research facilities were in on it: NIH, UC Berkeley, NYU, and right in our own backyard, Johns Hopkins. What they found was that psilocybin mushrooms were highly effective, not marginally effective or moderately effective, but highly effective at treating depression, anxiety, OCD, PTSD, sexual trauma, addiction, chronic pain. The list goes on and on. So I bought the full dose of psilocybin mushrooms at a dispensary in DC, rented an Airbnb in town, checked in, ground the mushrooms up into a powder, made a tea out of them, and off I went. I could spend the next 10 hours telling you about the details of my trip that night, but all I have time to tell you about now is that when it was over, my mind was quiet for the first time in my life. I felt centered and I felt healed. The suicidal thoughts had vanished. They were completely gone. Was my experience typical? According to Johns Hopkins, of all the people who participated in psilocybin studies, over 2/3 rated the experience among the top 5 events in their life, including the birth of a child. Yet psilocybin mushrooms are listed as a Schedule I drug along with heroin. I'm a regular middle-aged, middle-class professional father of 2. I don't go to concerts on mushrooms. I don't party it up on weekends on mushrooms with friends. It's not a quick way to escape my problems like drinking. I took mushrooms to treat my depression because nothing else worked for me and I tried everything under the sun. I now take a non-psychoactive dose 5 days a week in lieu of medication to keep depression at bay. They saved my life and it's made me a better husband and a better father and a better person. It can help millions of people. Thank you.
Madam Chair, I think Mr. Garrison's just here for questions, but if I might, because we have 5 folks who did agree not to testify at my request, but if experts in this field, if they could just stand up and show that they were here to support, I'd appreciate that. Thank you, Madam
And
Chair.
thank you all for your consideration. It's good news that the bills passed the House, so we'll certainly be looking closely at it. And Mr. Hamilton, I just want to thank you for your really incredible testimony, and I'm so happy that this has been such a positive experience for you.
Thank you, Madam Chair. I appreciate that.
Thank you. So do I have any questions from the committee of any of these members of the panel, the sponsor, or Mr. Garrison? Any questions? Thank you all very much.
Okay,
Very
thank
good.
you, Madam Chair.
Thank you.
And one final thing, don't keep Senator Hester too long because we got to get her down to voting session. So when you get to her, keep the questions tight, right?
Well,
Okay.
thank you. We have the Secretary of
Yeah,
Health
I
before
understand.
Senator
Thank you,
Hester,
Madam Chair.
so I'm sorry.
Thank you.
Thank you. Can I have Eileen Brewer, Hannah Glassman, Deborah Cervenik come to the table, please? If they're here. You're all, thank you very much. We have some virtuals. Who's here virtually, Tammy? Okay, Shanitha Lewis is a virtual favorable. You're all. Shanitha Lewis, are you with us? There she is. There she is. Hi.
Yes, I am. In lieu of time, I won't keep you all. I am the Executive Director of Veterans Initiative 22, and we urge a favorable report on SB 1. This could save lives.
Are you with us? There she is. There she is. Hi.
Hello, yes, I am. In lieu of time, I won't keep you. This could save lives.
Are you with us? There she is. There she is. Hi.
Hello, yes, I am. In lieu of time, I won't keep you. I apologize. It seems I have a bad connection. Thank you all for your time. This could
Thank you,
save lives.
Shanitha. Okay, and so I think our final witness is Eric Sterling. He's favorable with amendment. Mr. Sterling, if you'll unmute, you can begin.
I'm Eric Weintraub. I don't know if this is the right, I'm the right person. Is this the bill on opioids in the treatment in the emergency room?
This is a bill about psychedelics.
No, you got the wrong person.
Okay. You've got the wrong bill. Thank you. Is the other Eric there? Okay. Okay, thank you, Mr. Sterling.
Thank you, Madam Chair. I've submitted a written statement. I want to note, when you heard, for example, Dr. Koop talk about mescaline from cacti in his testimony, this points out the problem I wish to address. In the 1990s, after my years with the U.S. House Judiciary Committee, I was involved in the efforts to enact the federal law to protect the use of peyote for religious purposes by American Indians. That law has been very effective, but peyote is being plundered. The natural source of the sacrament is being plundered. And this leads to the problem in the bill, that the definition of natural psychedelic substances does not include peyote, which is a policy issue. The definition says naturally derived psilocybin, but what this committee really wants is naturally occurring, these compounds naturally occurring, not derived. Naturally derived would mean they couldn't be synthesized in laboratories, which means that to get mescaline, you would have to use peyote, which grows slowly. We don't want peyote to be used as the source of mescaline. We want laboratory-produced mescaline in order to preserve peyote for its religious indigenous use, as I point out in my testimony. So the amendments I propose: substitute naturally occurring for naturally derived, strike out the second line excluding peyote, and insert under the responsibilities of the task force that it has the recommendations to punish trafficking peyote or mescaline obtained from peyote. That's the policy you're trying to protect with respect to peyote, to punish the trafficking in peyote or mescaline obtained from peyote. I'm happy to take your questions.
Thank you very much. Do I have any questions for Mr. Strong? We do have your written testimony and our analysts will review that. Thank you very much. I
Thank
see
you,
no
Madam Chair.
questions. That ends the hearing on Senate Bill 1009. I believe Senator Ellis, you're up if the Secretary of Health is here. Madam Secretary, thank you for being here. We also have Teresa Lee and Larry Polsky, I think. Now, Senator Ellis, our secretary's favor with amendments. So let's start with your two favorables from your panel, Teresa Lee and Larry Polsky, and then we'll go to the secretary. Is that okay?
Yes, Madam Chair.
Thank
That's fine. Thank you.
Good afternoon, Chair Botto, Vice Chair Klausmeyer, and members of the Finance Committee. For the record, Senator Arthur Ellis, District 28, presenting Senate Bill 1059, Maternal Health Assessments, Referrals, and Reporting, aka the Maryland Maternal Health Act of 2024. This bill is cross-filed with House Bill 1051, which I must say passed unanimously out of committee last night, and sponsored by Delegate White Holland, who worked very hard. To be honest, she did the heavy lifting on this bill. And sometimes, you know, as an Air Force officer, I was taught sometimes you have to know when to lead, when to follow, or just get out the way. So with this bill, I followed the lead of my co-sponsor delegate, and she did a great job. Just want to say she worked with the health department, all the advocates, and got their how should I say, agreement on the final version of the bill that is presented here today. And this bill the Senate version will match exactly the version passed out of the House. So all that being said, I must say that maternal deaths and serious postpartum health incidents is a public health crisis that continues to disproportionately affect women of color statewide and nationally. Senate Bill 1059, this bill seeks to accomplish the following: require the Maryland Department of Health to make the Maryland prenatal risk assessment form and postpartum infant and maternal referral form electronic. Require all birthing hospitals to participate in the postpartum infant and maternal referral form, or PIMR. Convenes a work group to outline workflow recommendations to improve care coordination at the local level. Also, will report out the number of types and referrals at the local level. We'll also follow up with discharged patients within 24 to 48 hours and provide resources to patients post-discharge. also creates a report card for birthing facilities in Maryland that includes key quantitative and qualitative measures by race and age, and finally, requires all birthing hospitals in the state of Maryland to participate in the surveillance of severe maternal morbidity, or SMM. This bill presents a significant opportunity for the legislature to bolster existing efforts within the Maryland Department of Health, strengthen care coordination in the community, and equip our communities with the information they need during pregnancy and postpartum periods. Senate Bill 1059 is a legislative priority of the Legislative Black Caucus of Maryland and the Women's Caucus. The issue. I want to say fortunately, Maryland has made some improvements in maternal health, moving from a D to a C, according to the March of Dimes. We've had several bills to address this issue over the last few years, including a bill that was passed a couple of years ago and implemented now with the doula bill, which I was the lead sponsor on in the Senate. From 2018 to 2021, the Centers for Disease Control and Prevention reported that Maryland experienced 59 maternal deaths, and the maternal mortality rate in Maryland was 21.2 per 100,000 live births. Among these deaths, racial health disparities persist. In Maryland, Black women are 3 times more likely to die from a pregnancy-related cause than their white counterparts. Let me say that again, 3 times more likely. The March of Dimes also reported that the Maryland had 17.3% of birthing people receive inadequate prenatal care and 30% low-risk cesarean births for first-time moms, all higher than the national average. In 2023, the Maryland Maternal Health Innovation Program released key findings from a pilot surveillance program indicating that 374 of those severe maternity morbidity cases were identified among 13 hospitals from July 2020 to December 2022. Obstetric hemorrhage was listed as a primary cause for over half of these events. Let me skip over some in the interest of time and just say that we have some sponsor amendments which work with our health department and others to really get a wonderful product out of the many hours from early summer of last year until now. The work continues on this bill. And I'll just say that Chair Botto, Vice Chair Klossmeyer, and members of the Senate Finance Committee, I ask for a favorable report on Senate Bill 1059.
Thank you, Senator. Either Teresa Lee or Larry Polsky next. Larry, thank you.
My name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of SB 1059. This is a priority bill for the Legislative Black Caucus. This is also a priority bill for local health departments. SB 1059 lays a foundation for earlier identification of pregnant and postpartum women at higher risk for potentially life-threatening health problems. It also connects obstetric providers, hospitals and birthing centers, and local public health departments so available resources can be used more effectively and more efficiently. As a board-certified OBGYN who practiced for 2 decades in St. Mary's County before shifting to public health, I understand the value of more effective public-private partnerships that this bill will provide. SB 1059 will allow nursing and social support staff at each of your local health departments to more effectively address domestic violence, substance misuse, postpartum depression, and a host of other social factors that currently lead to unnecessary tragedy. Improved prenatal outcomes are also a major cost saver for the state of Maryland. 40% of pregnancies are covered by Medicaid. Adverse maternal outcomes often translate into preterm births. A single premature baby can cost well over $100,000 in neonatal intensive care unit expenses, and medical bills continue for a lifetime for the most severely impacted newborns. I do want to note for the committee that with the amendments adopted in the House, the fiscal note for local health departments is now 0. SB 1059 is a vital step as we work cooperatively to improve preventative measures and decrease adverse maternal and newborn outcomes. Thank you very much.
Thank you. And Teresa Lee.
Thank you, Madam Chairman. Good afternoon, members of the committee. My name is Teresa Lee, and I'm the Director for the Center for Quality Measurement and Reporting at the Maryland Healthcare Commission. I appreciate the opportunity to speak with you today in support of Senate Bill 1059. The Commission maintains a consumer website that provides quality and performance information on a variety of healthcare provider settings, such as nursing homes, assisted living programs, hospitals, and more. The information available on our website varies by provider setting. For some settings, such as urgent care or adult medical daycare, we include basic information to enable consumers to identify providers within their zip code. For other settings, such as hospitals, nursing homes, and home health, we report on a more robust set of measures and performance data to give consumers an opportunity to compare providers when making healthcare decisions. In addition to clinical measures, users can determine how patients or families rate their hospital or nursing home and whether they would recommend the facility to others. The hospital component of the quality reporting website displays information on services provided by all Maryland General Acute hospitals, including maternity services. Users of the site can identify hospitals that provide birthing services, review the volume of vaginal and C-section deliveries performed by each hospital, as well as the average charge per case for these services. This information is important to share with consumers, but we recognize we need to do more. The Commission supports Senate Bill 1059 and believes the quality reporting website can serve as a platform for establishing the proposed report card on the performance of facilities that provide critical maternal health care services to women across the state. We believe the report card can be developed with the Commission's existing resources and with our continued collaboration with the experts at the Maryland Health Department, excuse me. That concludes my testimony.
Thank you. So Secretary Herrera Scott, it sounds like you're going to say favor with the amendment, which is exactly what Mr. Polsky said, but thank you for being here. Sorry I made you wait.
So good afternoon, Chair Bidel, Vice Chair Klaus Meyer, and members of the committee, Laura Herrera Scott, Secretary of Health for the record. Thank you for the opportunity to speak to you today in full support of Senate Bill 1059, the Maryland Maternal Health Act of 2024. You already heard from Senator Ellis around the public health impact of maternal morbidity and mortality, and you also heard from Dr. Polsky around the coordination at the local health department to serve as the care coordination hubs. What the provisions of this bill do go one step further, and it's an opportunity to strengthen the system to form a greater connection between birthing hospitals, prenatal practices, local health departments, managed care organizations, community-based organizations, so that the care experience for the birthing patient is supportive, tailored to their needs, and coordinated. And as many of you know, we have a system of healthcare that's fragmented, and this is an opportunity to really bring everyone together to coordinate that care. We appreciated the opportunity to work with Senator Ellis and stakeholders to come together on consensus amendments and are fully supportive of the amended version of this bill. So we thank you for the opportunity and again, urge a favorable report.
Thank you very much. And it's such an important issue, and we've not been, Maryland as a state has not done very well with maternal health in recent years. So thank you for your support. Do we have any questions for this panel? No. Senator Ellis, thank you for bringing us a really good bill. Thank you.
Thank you, Madam.
We have three more people favorable with amendment: Joseph Wynn, Pam Casemeyer, and Tracy LaValle.
Hiya, good afternoon. Madam Chair, Madam Vice Chair, members of the committee, for the record, Joe Wynn, Executive Director of the Maryland MCO Association. I have very brief comments. I know you have to get back to the floor. The MCOs are supportive of this bill. It's very important to the MCOs. 40%, you heard Dr. Polsky mention that 40% of births in the state of Maryland are financed by Medicaid. This has been a collaborative process. On the House side, especially the sponsor on the House has held multiple stakeholder meetings and resolved a lot of the concerns. And this will build upon the collaboration and good work that's already been done in the state and is an important bill for the MCOs. And we urge a favorable report. Thank you.
Good afternoon. Is that where? Yep. I'm Tracy Laval, the Senior Vice President for Quality and Health Improvement at the Maryland Hospital Association. On behalf of Maryland's hospitals, I'm here to support Senate Bill 1059 with the sponsors' amendments. And I want to speak to a few of the elements. The independent reviews of a representative sample of maternal morbidity cases will bring additional clarity to the drivers of maternal morbidity and mortality and add to our understanding of what's needed to reduce the disparities in maternal health and to foster good outcomes for all birthing parents. What we know now is that many factors influence maternal outcomes, including the age, health, and environment of the mother before pregnancy, during postpartum support, and the trust and relationship with doctors and caregivers throughout the perinatal period. The requirements of the bill build on existing programs and upgrade existing processes. We're fortunate that the MD Mom program has created the infrastructure to do the severe maternal morbidity reviews, and MHA is pleased to support and amplify that work. The bill mentions specific forms completed by hospitals and physicians in the prenatal and postpartum period that refer high-risk patients to local health departments to connect families to local resources specific to the family's needs. We appreciate the planning that's underway to simplify and modernize that process. And as the state plans for the next Maryland model, strengthening the ways in which hospitals, local health departments, and community organizations work together will be beneficial. I appreciate the opportunity to share our views today. Thank you.
Pam Casemeyer.
Hi, yes, Madam Chair, members of the committee, Pam Casemeyer. I'm here on behalf of the American section or the Maryland section of the American College of Obstetrics and Gynecology, the Mid-Atlantic Association of Community Health Centers, the Academy of Pediatrics, and also the State Medical Society. I cannot add to anything that's already been said about this bill, other than to thank all the stakeholders, the sponsor here in the Senate and in the House, to ultimately end up with a product that everybody agrees will advance maternal child health. And with that, I'd say we request a favorable report.
Thank you. Do I have any questions for this panel? Thank you all very much for your support. That ends the hearing on Senate Bill 1059. Senator Hester. Senator Hester is bringing us Senate Bill 957. And there's one favorable virtual.
There should be two.
Well, the other is favorable with amendment.
Okay.
So we'll get to both of them after your presentation.
Thank you, Madam Chair, members of the committee. For the record, Senator Katie Fry Hester, asking for your consideration of Senate Bill 957, which aims to reduce the risks associated with automated employment decision tools. As I mentioned earlier today on the floor, yesterday the European Union passed the EU AI Act, and I just wanted to read a quote from their press release where they're talking about, in the 900-page bill, the obligations for high-risk systems. It says clear obligations are also foreseen for other high-risk AI systems due to their significant potential harm to health, safety, fundamental rights, environment, democracy, and the rule of law. Now, this is the part where it gets interesting. Examples of high-risk AI include critical infrastructure, education, vocational training, employment, essential private and public services, and healthcare and banking. Such systems under this act must assess and reduce risks, maintain use logs, be transparent and accurate, and ensure human oversight. Citizens will have a right to submit complaints about AI systems and receive explanations about decisions based on high-risk AI systems. And so what this bill is seeking to do is to provide safeguards on the accountability in the use of automated employment decisions, ensuring that the applicants are informed and protected from the negative consequences of the automated decision-making systems. I want to share with you a letter that we received from Workday, which should have been emailed to your office. Workday, as you probably know, is an AI developer for enterprise systems. It does financial management and human resources. It is used by 10,000 organizations and half of the Fortune 500. What they say in the letter is that there are lots of data points that suggest that AI systems are very quickly used to screen resumes, as in that nearly all large companies use them. And many data points suggest that the use of AI-driven personality tests and other AI-based candidate assessments have become widespread. For example, a recent not quite scientific survey indicated that 99% of Fortune 500 companies use AI to screen resumes, and 43% of companies were planning to use AI to interview or talk to candidates this year. Colleagues, that worries me. So basically what this bill does is it prohibits employers from using automated decision tools to screen their applicants for employment or for compensation or other terms, unless that system has undergone an annual impact assessment. Based on what the European Union has just done, all those companies are going to have to be doing it in Europe. And so it shouldn't be that large of a lift. The employer, under this bill, the employers are required to notify each applicant within 30 days of their use of an automated decision tool and provide information about its use and the applicant's assessed job qualifications and characteristics. The last thing the bill does, it is establishes civil penalties for employers violating the notification requirement to ensure the provisions of the act. There is an amendment that you have that strikes the definition of high-risk language from the bill and thus simplifies the application of the regulations. What I would like to do is to draw your attention to two other pieces of testimony that you have. I learned a lot during this process. There is a letter from the Maryland Education Association that notes in May 2023, the Equal Employment Opportunity Commission released technical assistance related to the use of AI in employment and implications for Title VII of the Civil Rights Act. In August of 2023, the Employment Commission reached a settlement with a tutoring company regarding allegations of AI discrimination in hiring in violation of the Age Discrimination in Employment Act, the first of its kind. Relatedly, certain states have proposed legislation to establish protections for job applicants and workers to address the potential discrimination that is coming from automated employment decision technology. I also want to point out to you this really interesting letter from the Maryland State and DC AFL-CIO. At the end of their letter, they say, artificial intelligence has no place in major hiring and employment decisions. This technology is way too early in its development for deciding whether a family can put food on its table. Reasonable guardrails must be put in place to ensure that job applicants are informed so they may take action if these programs are found to be discriminatory. Senate Bill 957 represents the bare minimum of what Maryland needs to do to combat the potential downsides of AI and employment issues. And so, colleagues, I would argue that this is the bare minimum. It is not a ban. It is not a ban on artificial intelligence. What it's saying is, if you are a company, you are going to use artificial intelligence to make decisions about who you hire and how much you pay them, you must do a minimal assessment. This bill prioritizes the rights of job applicants. It upholds diversity and civil rights. It promotes fairness and equity in all employment decisions. And with that, I would ask for your favorable report on Senate Bill 957 as, your favorable report on 957, as amended. And then I have two virtual witness, Madam Chair, and I'm happy to take questions as well, but I also have to vote downstairs.
You want to ask questions of you now?
Yeah, I think that would be
And then you
great.
can go.
And my very competent Chief of Staff, Damian Lang, knows this bill inside and out and can help answer questions as well.
So does anyone on the committee have questions for Senator Hester? Okay, go vote. Thank you.
Thank you so much.
So we have Gabriella Waters, virtual. Gabriella, unmute and please start your testimony.
Thank you, honorable members of the Finance Committee. My name is Gabriella Waters. I'm from the Center for Equitable AI and Machine Learning Systems at Morgan State University. And as Senator Hester just outlined, the use of AI in resume screening can and does present some challenges. Despite all the advancements we've made in this technology space, AI still isn't infallible, and we can't treat it as though it is. It's always trained, and those data sets can present issues when screening resumes and looking at potential candidates from anything from where you went to school, the clubs you belong to, the sororities or fraternities you belonged to. That can influence the decision of the AI favorably or unfavorably in any situation. These tools also lack transparency most of the time. So candidates don't know that they have been rejected by an AI and not a person, and they aren't giving any detailed feedback on what went wrong or a rationale for this decision and how it was made. The industry overall has a huge reliance on AI for resume screening, and it risks continuing to filter out talent that could be applied and leveraged in our state. So Senate Bill 0957 isn't just about the biases and the transparencies. It's also about a commitment that the state should have to fairness and equal opportunity for all job seekers. And so I urge a favorable report on this bill. Thank you for your time.
Thank you very much, Gabrielle. And now we have Matt Shearer. Matt, you want to unmute? There you go.
Thank you, Chair Bidle, Senator Hester, committee members. My name is Matt Scherer. I lead the Workers' Rights Project at the Center for Democracy and Technology, where I advocate for workers' digital rights. Companies increasingly use AI and other automated systems to make decisions that dramatically impact workers' lives and livelihoods. CDT has been closely watching as policymakers across the country grapple with how to manage the potential benefits and risks that these technologies pose. I can't tell you how much I appreciate the effort that Senator Hester and Delegate Bartlett put into this thoughtful and precise legislation, which addresses the very real risk of discrimination and bias that AI decision systems pose to Maryland workers. I particularly like the bill's requirement that companies evaluate these systems to determine whether they would likely result in unlawful discrimination, the prohibition against tools likely to result in such discrimination, and its requirement that companies notify workers subjected to automated decisions. CDT's position on this bill is favorable if amended. Our recommendations are designed to ensure this bill's effects match its spirit and are strongly guided by the failure of New York City's AI hiring ordinance. A recent study, which Delegate Queen referenced in the hearing regarding the House version of this bill, found that employers have almost completely ignored that New York City law since it went into effect last year. Specifically, companies have avoided compliance by exploiting that ordinance's narrow scope, inadequate notice requirements, and enforcement provisions that do not provide adequate deterrence. There are a few provisions in SB 957 that, if left unaddressed, could leave it vulnerable to a similar experience. Consequently, I urge you to amend SB 957 to strengthen its notice and disclosure requirements and clarify its key definitions to ensure companies cannot avoid disclosure and, by extension, compliance with the bill as they have in NYC. I've prepared a red line with suggested amendments that I can share with committee members that would accomplish these goals. Thank you again for your attention to these vital issues. I'm happy to take any questions if the committee has them.
Thank you. Do I have any questions for Matt and Gabrielle? I see no questions. Thank you for your testimony. That ends the hearing on Senate Bill 957. Next, we have Senate Bill 1071, Senator McKay, hospitals opioid overdose.
May I bring up my panel?
You may.
Thank you.
I have a list here. I don't know if these are all your panel. Ellen Weber,
I've got 3 or 4.
Jim
looks like
Murray,
3.
you know, Ann Seacott.
4. Got
Sharika-
4.
4.
Anybody want to be 5? Anyone want to be 6?
You know, and I will tell you, Me Too works really well. Thank you.
Well, there goes that 45-minute presentation. Madam Chair, members of the committee, thank you very much. It's proud to present Senate Bill 1071. First of all, we know we have an epidemic on our hands regarding to the opioid-related overdoses. Overdoses of opioids have increased 345% between 2021 and 2016 in the United States. Medicated treatment of opioid use disorder is a proper way to combat this opioid use disorder. This bill, Senate Bill 1071, will allocate $500,000 from the Opioid Restitution Fund of the Department of Health to train docs in the treatment of their patients in a hospital setting. It will also show that Maryland is taking a critical step forward in addressing this opioid crisis. I'm very supportive of the amendments that have been
presented and to make House Bill 1155 in the same posture if it is this committee's desire. I'll just end with me too with a favorable report.
Can we start at the end closest to the podium and just go right down the row? Thank you.
Good afternoon. My name is Drew Fuller. I'm speaking in favor of this bill on behalf of myself, my patients, and many of my colleagues. I've practiced medicine in Maryland for 28 years, and I'm board certified in both emergency medicine and addiction medicine, but I'm coming to the committee today as a patient safety specialist. I had the honor of being a chief safety officer for the largest emergency medicine group in the Mid-Atlantic when we instituted a program when we launched buprenorphine protocols in 23 hospitals in Maryland and Virginia. It seemed like a big win 5 years ago. Unfortunately, there were no mandates, so the clinicians can choose whether to follow the protocol or not follow the protocol. This is still the process for many of the hospitals in Maryland. Many hospitals probably have protocols that allow for this gold standard treatment for opioid use disorder. However, there are no mandates. I transitioned from emergency medicine to addiction medicine in 2019 to help start the opioid crisis response program for the Calvert County Health Department. I was moved to do so because so many of my patients were not getting access to care both in hospitals and in community settings. And if we're focused on this from the patient safety standpoint, these are preventable deaths. When patients are encountering care within hospitals, it is strictly up to the discretion of the clinicians whether to provide this care or not. This is not difficult care. And in fact, most of our hospitals are actually already there for the most part. They have protocols that are in place. We have eager clinicians that are wanting to move forward. But when we look at patient safety and we look at, we need systems of high reliability, we can't rely on systems of hope. We can't hope that a practitioner will provide the care. We can't hope that people will be connected to outpatient services. We must have reliable systems. Within the next 10 years, it's predicted that 20,000 Marylanders will die of an opioid overdose. This does not have to be the case. So I would state that this is not only a patient safety issue, but actually a public safety issue, one that quick action is needed.
Hi, my name is Jim Murray. I am a program coordinator, peer support specialist, certified peer supervisor for AHEC West in Cumberland, Maryland. I've been a peer for 5 years. I started off my peer work at a hospital in Western Maryland, which is now UPMC of Western Maryland. While I was there, we started a fast track program, which was where people come in and they're withdrawing or overdose from opiates. We would get them a dose of buprenorphine in the ER and then set them up for treatment on the outside. I found that really highly successful. Problem is that I found with that is if a peer wasn't there, it didn't get done. So the rest of the hospital staff was not trained, and it was the peers that had to take over and pretty much guide the providers into what to do and how to do it. I got at least 30 people in my 3 years there into some kind of program, coming out just from the ER with a bupe dose and with a setup appointment for them to continue on the outside. I had one patient that came through 2 years before, and she caught me in the emergency waiting room and told me I helped save her life. I got her a dose while she was in there. She went to treatment. She had been totally clean and sober for 2 years. She had a new child, new husband. She said life was going good and things are going well with her. The OUD, opiate use disorder is huge. I am a person in recovery. I am a person that tries to reach out and try to help anyone and everyone. And the ERs, also are doing what they can for that. But it needs to be continued. And I think it needs to be expanded really. And it not just what peers know about it, but what the providers, the nurses, the crisis counselors, everyone that's in the ER should know how to do this and perform this. I am a huge proponent of SB 1071. Thank you for your time.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. I'm Ellen Weber. I'm with the Legal Action Center testifying in favor of SB 1074. We thank Senator McKay for introducing this bill and for conforming the Senate bill to the House amendments. Based on our legal research, Marylanders clearly have a right to receive specific and non-discriminatory medical care when they go to an emergency department with an opioid-related overdose or emergency medical condition. This includes screening, diagnosis of an opioid use disorder, administration of buprenorphine as appropriate, and a facilitated referral to community-based treatment. The Emergency Medical Treatment and Labor Act, otherwise known as EMTALA, requires EDs to screen patients for a medical emergency, and this includes life-threatening conditions related to opioid use, and to stabilize that condition before the patient is discharged. Under EMTALA, the treatment must reasonably ensure that the individual's medical condition will not materially deteriorate at discharge. And this means that EDs must offer buprenorphine to treat opioid overdose and link that patient to treatment. Because without treating the patient's withdrawal symptoms or their cravings, which buprenorphine does better than any other medication, and referring them to ongoing care, that practitioner knows that the individual will resume drug use, placing their lives at risk often immediately after discharge. And hospitals also can violate the Americans with Disabilities Act, which bars EDs from denying health services to individuals solely on the basis of their drug use or refusing to make a reasonable accommodation. So some hospitals deny decisions based on negative and stigmatizing stereotypes about people who use drugs. The denial of buprenorphine or an effective referral to treatment to treat opioid use disorder, if based on such stereotypes, can violate the ADA. And the ED may also violate its reasonable accommodation obligation by refusing a patient's request for buprenorphine or assisting with accessing care. Thank you very much for your consideration. We urge a favorable report.
Madam Chair, members of the committee, I'm Ann Seacott, representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence. You have our written testimony. Me too.
Yes.
Thank you.
That's
Ann
happy
gets
ending.
extra points. This is your entire panel?
Yes, ma'am.
Do I have any questions for this panel or for the sponsor? I don't see any questions. Thank you, Senator McKay.
Thank you. Thank you.
Thank
We have a few more people signed up. We have Sharika Green. Is she here? No? Yes, okay. Sharika, come up and then we'll hear one virtual witness. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Sharika Green, and I serve as the Overdose Prevention Program Manager from the Baltimore City Health Department. I am here today representing Baltimore City Administration in support of Senate Bill 1071. In my role, I manage Baltimore City's Levels of Care program, a collaborative initiative between the Baltimore City Health Department and Baltimore City Hospitals, aimed at standardizing evidence-based care for patients with opioid use disorder. Through the program, the Baltimore City Health Department makes recommendations and provides support assisting hospitals in implementing best practices. These include screening patients for substance use disorder, maintaining the capacity to initiate treatment for opioid use disorder, offering peer recovery services, and facilitating connections to outpatient treatment. Because of this program, all Baltimore City hospitals screen patients for SUD, have peer recovery specialists on site, and initiate medication-assisted treatment. Senate Bill 1071 takes a similar and much-needed approach to implementing standardized protocols for hospital treatment of patients with substance use disorder. Hospitals play a pivotal role in addressing the opioid crisis. They serve as essential hubs for delivering comprehensive treatment and support to individuals at high risk for opioid-related overdoses and are uniquely positioned to address both immediate medical needs and the broader complexities of addiction. Importantly, people who might not otherwise access addiction services or treatment may come through the emergency department. Each time someone with opioid use disorder visits an emergency room is an opportunity to connect them with ongoing care and support. if our hospitals are ready and equipped to do so. For these reasons, we request a favorable report on Senate Bill 1071. Thank you.
Thank you, Sharika. And next we have virtually, let me see, are there any questions for this witness? No questions. Okay, thank you. And now we have virtually Eric Weintraub.
Thank you. I'm a physician who works at the University of Maryland School of Medicine. I'm a professor of psychiatry there, and I run the addiction programs at the University of Maryland. Can you hear me okay?
Sir, we can hear you.
For the past 25 years, I have focused on treating individuals with substance use disorders throughout the state of Maryland, with a focus on those individuals with opioid use disorder and injection drug use. At the present, as you know, we are in the midst of an opioid overdose epidemic, and Maryland is in the epicenter of that epidemic. All levels of our society are being impacted. There are highly effective treatments for this chronic illness, but unfortunately, they are underutilized. Medications for opioid use disorder, including buprenorphine, are highly efficacious, and their use has been shown to reduce opioid overdose deaths by greater than 50%. They are considered the gold standard evidence-based treatment for OUD and are recommended for use by every major health organization in the world. However, only about 25% of individuals with opioid use disorders receive these life-saving medications. Emergency departments are one of the places that individuals with OUD present for treatment and care. Many people, when they are in the ED, are suffering and are ready to consider making changes to their lifestyle, including stopping the use of illicit drugs. Like other chronic medical illnesses, cardiovascular disease, diabetes, patients with OUD should be diagnosed and treated within the ED setting, and referrals for continued outpatient treatment should be made so the treatment can continue upon discharge. It is poor medical practice not to do so. The position of the American College of Medical Toxicology, American Academy of Emergency Medicine, and American College of Emergency Physicians is as follows. Support the administration of buprenorphine in the ED as a bridge to long-term addiction treatment. Just one last sentence. People who use drugs, alcohol, opioids deserve the right to be offered available gold standard life-saving evidence-based treatment while being treated in the ED like those who have other chronic illnesses. Do not do so. It's discriminatory and represents poor medical care. Again, I am also in support of this bill. Thank you very much for the opportunity to testify.
Thank you, doctor. Do I have any questions for this doctor? No questions. Thank you very much. That ends the hearing on Senate Bill 1071. And now we're going to have Senate Bill 1018, Senator Washington. And Senator Zucker is on his way because we're joint with B&T. And you have one witness, Senator Washington?
Yes. Thank you, Madam Chair, members of the committee. Senator Alonzo Washington here to present on Senate Bill 1018. This bill creates an equity fund for tobacco manufacturers that are not included in the Escrow Act of 1999. This would level the playing field between legacy and new tobacco, as they both cause the same damage to the state, but pay differently. Every cigarette represents an equal cost to the state of Maryland, an equal cost to its residents, its health, its cleanliness, and yet legacy companies are paying more while newer companies don't contribute their fair share. The escrow fund has been too light on companies for the state, where it has been used as a savings account rather than a way to punish sellers for their previous actions. Firms can simply withdraw their money after 25 years of it being unused and are allowed to withdraw the monetary interest on those funds. Thus, the state needs to have a more permanent solution that better covers its needs for tax dollars that pay for the damages of cigarettes and reduces their consumption. We have seen companies that leave the escrow fund increase their sales by 9-fold, and thus keeping their taxes high is the best way to avoid increases on sales. For these reasons, Madam Chair and members of this great committee, I urge a favorable report on Senate Bill 1018. Thank you.
Good afternoon, Chair Bidle, members of the committee. Thank you very much. I'm John Leovi, Chief Counsel for Tobacco Enforcement for the Attorney General's Office. I urge a favorable report on Senate Bill 1018. The gist of my testimony was in my written statement where I gave you two charts. One showed the situation we have now with two cigarettes being equal in the amount of harm they cause human beings and Maryland taxpayers through our Medicaid program. There's two kinds of companies that join the master settlement agreement, those that have not. Companies that have joined the master settlement payment pay the same state excise tax, same federal excise tax, pay 90 cents in settlement payments, goes to the CRF. The companies that didn't pay 86 cents into their own escrow accounts. They earn interest and they get the money back in 25 years. They use it to underwrite sales. That's not fair. It's not fair to Maryland taxpayers who suffer the harm from their cigarettes. $619 million to our Medicaid program last year. It's not fair to us. What's fair is the equity fee, and that's Senate Bill 1018. Now, you'll hear some opposition. It will affect 3 cigarette companies that are allowed to sell in Maryland right now. All of them are located outside Maryland. One is coming in today. It's the company that Senator Washington discussed. A new one to Maryland. Its sales increased 900% in 2022 and nearly doubled last year. They can join the MSA anytime. They've chosen not to. They'll give you a lot of arguments about fairness or about the MSA or the intentions, but it's all a smokescreen. It's all a diversion from the fact that our current system gives companies like that a significant advantage in the marketplace, allowing them to cause the same amount of harm to Maryland smokers and frankly, Maryland taxpayers without paying their fair share. What's fair is to make them pay. And that's why I urge favorable report on Senate Bill 1018. Thank you.
Thank you. Do I have any questions for our sponsor or yes, Senator Hershey?
Thank you very much, Madam Chair. Mr. Leovi.
Yes, sir.
Yeah. How long has this current system been in place?
The master settlement agreement was signed in 1998. The original escrow act, I believe this body passed it in 1999.
99. So over
yes, sir.
20 plus years,
25. Yes, sir.
Years. And how many have you come to the General Assembly more than just this time requesting this method of
no,
your
this
work?
is my first time. This is the first time we've had this bill before this body.
First time in 20. So the first time in 25 years, what's really initiated this? What are we really trying to do here?
Yeah, what's happened is we've gotten a new kind of cigarette company that's been very frank, and you'll hear from them. They're going to testify today about being able to work the system. And they're very frank in their written testimony that they use the interest to underwrite their business expenses. It's a new marketing plan that actually takes advantage of the current system to use the escrow accounts, which were designed to be a source of recovery from companies that came in and left, to use them to underwrite their operations permanently. This company in particular is new to Maryland. It came in about 2018. And like I said in my testimony, it's grown very rapidly in the last couple of years. So that's barely been the change. The other change, of course, is that we're going to start handing the money back that's been on file for all these years. And this bill doesn't do anything with the amount of money that's in escrow. It's really prospective.
So for the next 25 years, you'd still have to give them money back.
Yes. We would.
So
yes.
when does this, when do you start seeing some type of difference that you're looking for here?
As soon as you pass this bill, because as soon as you pass this bill, the companies that now use the escrow as a piggy bank to underwrite current operations, sell cheap cigarettes with all the causes and all the consequences they have, will start paying directly to them, to us, which will go to the Cigarette Restitution Fund. So as soon as you pass this bill, you'll start to see a change. You'll start to see fairness in the market.
And at the end of the day, are we just trying to eliminate smoking altogether?
You know, I found out recently that states can ban smoking if they want to. I was surprised to learn that. I'm not here to talk about that today. But that would be up to all of you.
Okay. All right. Thank you very much. Thank you, Madam Chair.
Do I have any other questions for the sponsor or Mr. O'Boy? Thank you very much.
I just want to say that my job is the worst elevator speech of all time. Happy to discuss with anyone, anytime, if I can clarify in the future. It's a weird job. Thank you.
Thank you. We have weird
Thank you.
jobs too. It's okay.
Thank you all. Appreciate
Thank
it.
you. We have some unfavorables. Dustin McDaniel, Eric Estes, Ralph Brown, and Michael Johansson. These are all unfavorables.
Thank you, Madam Chair. We'll start with Dustin, Eric, Ralph, and then I'll conclude.
Thank you, Madam Chair and members of the committee. My name is Dustin McDaniel. I'm a former state House member, Democratic member of the Arkansas House, and two-term state attorney general. As tobacco co-chair of the National Association of Attorneys General for 4 years, I focused on NPM issues, and today I represent companies working with state AGs, including Excalibur. Tobacco is a harmful and addictive product, so it is heavily regulated and highly taxed. For generations, tobacco companies broke the law and lied about the effects of smoking, and AGs sued them and executed the Master Settlement Agreement in 1998, and it still generates roughly $7 billion a year for states. Excalibur didn't exist until 2001. It has broken no laws, pays all of its taxes, and pays into the Maryland escrow accounts, which holds funds to the benefit of the states in the event of future NPM litigation. Escrow accounts were created by the MSA and work as designed. They protect states' interests for decades, even if an NPM goes out of business. Escrows are not slush funds for NPMs. They are the state's insurance policies for future claims. The bill is not equitable as it doesn't create similar rights for NPMs as it holds for big tobacco. It neither levels the playing field nor closes the price gap between NPM and PM products. The bill simply imposes a penalty on companies that broke no laws and exempts and benefits big players that control 99.3% of your market. The fiscal note estimates it will cost $2 million to generate $500,000 in fees. HB 1073 is a tobacco tax bill that raises $40 million annually for Maryland, will reduce smoking, and is fairly applied to all concerned. Respectfully, this bill does none of those things and should not advance.
Go quickly. We are really running out of time. So I think Eric's next.
Yes, my name is,
Please.
my name's Eric Estes. I'm General Counsel of Excalibur International. Prior to joining Excalibur, I ran the state of Arkansas's tobacco litigation enforcement system. I wish to address two issues today. The first is the interest argument made by the proponent. The ability of an NPM to access interest on escrow accounts was not an unintended loophole in the law. It was the underlying purpose. This is clear from the clear language of the statute, as well as the fact that states have consistently argued that these escrow allowances make the escrow system constitutional. Further, despite arguments otherwise, this bill is not really about interest at all. If it were, it would seek to disrupt the ability of all manufacturers, regardless of MSA status, to access interest on funds. Altria and Reynolds place approximately $68.2 million per year into savings or investments for sales in Maryland alone to cover their MSA obligations. From this, those two companies make make millions of dollars in interest, as opposed to our thousands. This is money that they keep. It does not go to the state. If this bill was truly about interest, this issue would be the one to be addressed. Second, on its face, the bill states that it wants all manufacturers to pay equally, regardless of brand or MSA status. I respectfully assert this is a falsity. Mr. Leovi states that PMs pay approximately $9 per carton, while the NPMs pay approximately $8.60. This fails to take into account a subset of participating manufacturers under the MSA, so-called exempt or grandfathered SPMs, that pay only $5.30 a carton, $5.30, according to our estimates. This bill does not create a level playing field, but unfortunately props up big tobacco at the expense of us.
Thank you, ma'am. Thank you, Madam Chair and committee members. I appreciate the opportunity to be here today. Thank you for letting me to be here.
My name is Ralph Brown. I'm the Vice President, Governmental Affairs for Cheyenne International of Grover, North Carolina. Cheyenne is an NPM cigarette manufacturer as defined by the 1998 Master Settlement Agreement. Cheyenne is a tobacco manufacturer that began its business in 2002. I'm here today to discuss the reasons why my company, Cheyenne, is not supportive of SB 1018. It is Cheyenne's belief that SB 1018 will not deliver the benefits that the bill sponsor had hoped to accomplish in its passing. The bill does in fact place a fee on a certain group of manufacturers that sell into your state of Maryland, but it does not raise the funds that the state could receive if the bill was to apply to all cigarettes sold in the state that are manufactured by the original signers of the Master Settlement Agreement in 1998, OPMs, and the subsequent signers known as SPMs. You've already heard from my colleagues that the issue involving the Master Settlement Agreement are complex and involve many parties, including 48 states, and at least 3 different types of tobacco manufacturers. You've heard the AG suggest that he wants to level the playing field between the PMs and NPMs. First, we of course oppose that because the state should not equate the PM's restitution payments with the NPM's escrow accounts. That is not a level playing field. Second, the AG has failed to recognize the existence of a third type of tobacco manufacturer. These are exempt manufacturers, and they pay the amounts that differ for both the PMs and the NPMs. And usually the exempt manufacturers pay less than both the others. The AG's bill does nothing to level the playing field amongst all 3 and would result in an increased disparity between what is paid by NPMs and the exempts. If level playing field is the goal, this bill does not achieve it. If all tobacco companies should pay for the costs associated with tobacco use, the best way to achieve that parity and to raise significant funds for the state is to raise tobacco tax on all cigarettes. Not only will this generate funds, it will reduce tobacco consumption. Thank you very much.
Thank you, Madam Chair. I'm Mike Johansson on behalf of Excalibur. I'll try and be brief. All tobacco companies pay $3.75 per pack on each cigarette, no matter what type of manufacturer you are. At retail, it's a 6% general sales tax on the retail price. Everybody pays the same. When it comes to legacy manufacturers, those that were found to have done bad things, the participating manufacturers, they are paying restitution forever, and they should. And it results the state receiving about $138 million a year. Those restitution payments are being paid by them because they did bad things. The non-participating manufacturers, including Excalibur, are paying into an escrow account in case they do something wrong, which they haven't, okay? And to think that the interest earnings on an escrow account is a boon, let me ask you this. If you were forced to put $100 away each year, and you got 5% in interest a year, you got $5, but you couldn't get the 100 back for 25. How many of you think that's a boon? Lastly, the fiscal note says from the Comptroller's office, in order to collect this $450,000, which is going to escrow and make it a tax, the Comptroller needs $2 million to upgrade her computer system. We oppose the bill.
Do I have any questions for this panel? So what do you think the purpose of the bill is, Mr. Johansson?
It's a misguided way to level, quote, the playing field by mixing up escrow payments and restitution payments. But leveling the playing field would also involve those exempt manufacturers that you heard my colleagues talk about, which weren't addressed at all by the proponents.
Thank you.
Thank you.
I don't see any other questions. That ends the hearing on Senate Bill 1018. Senator Washington, we have Senate Bill 1020. You have Bridge Dumais and Antonio Brooks. I just want to mention this. It is now 4:20. We're back on the floor at 5:30. We have 20 bills to vote. Just want to put that out there for you. Thank you.
Yeah, I thought this was the last bill of the year and last bill of this hearing today. Madam Chair, members of the committee, thank you, Senator Alonzo Washington here to present on Senate Bill 1020. The Safe Staffing Act will ensure that every hospital in Maryland creates staffing committees in which half is direct care workers representing the entire care team. This means nurses, technicians, support staff, environmental service workers, and dietary aides. We have worked, this group of people up here that you can see, and many others have worked really hard with the Maryland Department of Health and advocates to amend the bill to its current form, which simplifies regulations and eliminates the fiscal note. Instead, the amendments that I have in front of you, instead of having HS CRC, it was decided that the best entity to provide oversight is the Office of Healthcare Quality. As such, sponsored amendments are being put forth to make this change. Additionally, the Maryland Nurses Association presents proposed amendments that are considered friendly and submit these as a sponsor amendment as well. We have also decided to simplify regulations language so less additional staff is required, which will decrease the fiscal note considerably. As you all know, the 2022 report indicates that 1 in 4 nursing positions are vacant, with 62% surveyed Maryland Board of Nursing licenses and certificate holders indicating that they thought about leaving nursing recently due to feeling overworked, burned out, and underappreciated. For these reasons, Madam Chair and members of this great committee, I ask for a favorable report on the Safe Staffing Act of 2024. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Bridge Dumais. I'm the political coordinator with 1199 SEIU. We're the largest healthcare workers union in the nation with 10,000 members right here in Maryland. The hospital workforce shortage is not due to a lack of workers. Rather, it is the lack of dignity and respect when workers raise concerns about short staffing, chronic burnout, and workplace injuries. Therefore, we urge a favorable report on the Safe Staffing Act. The hospital throughput work group to address long emergency department wait times failed to adequately incorporate the entire care team, including technicians, environmental service, and dietary workers. We still have the longest wait times in the country because those workers did not have a seat at the table. Please don't make that same mistake with the short staffing crisis. This bill is an opportunity to solve the staffing crisis the right way by ensuring workers' voices are heard. While safe ratios are important, safe staffing committees can also adjust staff assignments, test and track the efficacy of staffing strategies, and yield data that's useful to lawmakers and state agencies. Healthcare workers support this bill, not only because it will address dangerous working conditions, but because it will improve the quality of patient care. Short staffing means patients are suffering. I've heard horror stories from workers about patients lying in bed for 12 hours calling for help before someone could assist them. Psychiatric patients who are supposed to be supervised have been left alone to wander the hallways where they could hurt themselves or others. Bed sores, pneumonia, and falls are all increasing. Surgeries and treatments are frequently postponed. Testing and administration of medications is often delayed. Healthcare workers provide high quality care, but it is impossible to be 2 places at once. If we don't address this crisis with worker-led solutions, patients will not get timely care. Health costs will continue to rise, workers will remain at risk, and it will be harder to fight off the next public health emergency. I urge a favorable report on SB 1020. Thank you.
Antonia.
Good afternoon, Madam Chair and committee members. My name is Antonia Brooks. I'm a physical medicine and rehabilitation technician 2 in the ICU, member of 1199. I work short staff multiple times a week. Healthcare is a human right. Short staffing delays the right. I urge favorable report on the Safe Staffing Act. We have long emergency department waiting times. Patients are being treated in hallways. I treat 24 patients per day, helping them walk, sit up, providing respiratory assistance. I work along the side of the nurses, the doctors, and physical therapists. On days we are short-staffed, I assist other areas too. That means I spend half of my time with patients on those days. Treatments that patients are supposed to receive daily often get postponed because of short staffing. The cause of short staffing is healthcare workers, underpaid, overworked. Workers are quitting soon after being hired because they are required to take on outside of their job description, causing burnouts. The Safe Staffing Act will improve patient care, reduce emergency department waiting time, increase workers' morals. Right now, when workers bring out concerns about staffing to manage, we ignore. This bill will change that by giving workers like me an opportunity to bring our solution to the table. I'm excited to volunteer to the service of the Hospital Safe Staffing Committee when this bill is passed. Please vote yes, SB 1020. Thank you.
Good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Nurses Association in support of the bill, and just want to note our appreciation of the sponsor and the advocates for reaching out to us very early in this process. So the Maryland Nurses Association is at support for a couple of reasons. First of all, this bill, and I've seen the department's amendments, really takes the collaborative approach in terms of developing jointly solutions between the people who are on the direct care side and the people who are managing the process. It's very important to M&A that not it's just nurses, but we have radiologists, technicians, we have medical assistants, CNAs, all types of people involved in the process. The second thing I just wanted to note is there was a bill that passed in 2013. It's very similar, that created staffing or workplace safety committees in hospitals and nursing homes. And so those committees could possibly even be used to work on the issues in this bill. With that, we ask for a favorable report, and thank you for your time.
Senator Lamb.
Thank you, Madam Chair. Just a question for this panel. It looks like a lot of the opposition seems to cite that this could lead to bed closures in some of our hospitals. Obviously, we have, a crisis in our emergency departments, a need for additional staff and whatnot. What's your take on whether this would exacerbate those kind of concerns?
Thank you for that question, Senator Lamb. This bill does not mandate the hospital to make any decision that will negatively impact the fiscal budget or patient care. In fact, the bill's intent and what it has accomplished in 9 other states shows that the bill can improve workplace safety, worker satisfaction, patient care, and throughput. The bill only mandates a process that is transparent and collaborative. It does not mandate an outcome or a specific ratio. The staffing committee just suggests guidelines and tracks efficacy. And the beauty of a staffing committee is its flexibility. They can always come back later and adjust the plan as needed to make sure it is working for the hospital, for the patients, and the workers. So again, this is about establishing a process, not an outcome. Thank you.
So it's really just about creating committees and kind of planning.
Absolutely.
Okay, thank you.
Questions for this panel? Thank you very much. All right, I'm going to call 7 unfavorables. 6 of you can sit at the table and 1 of you can stand at the podium. Pegeen Townsend, Mandy Bounds, Kayla Wallace, Lynn Marie Rosino, Stacy Mann, Brandon Floyd, Kimberly Elliott. And you, Pegeen, you can begin as soon as you're ready. Oh,
could I have Brandon start?
Sure, Brandon can start.
Thanks.
Hurry, Brandon, quickly.
Yes, ma'am, I understand.
Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Brandon Floyd on behalf of the Maryland Hospital Association, testifying in opposition to Senate Bill 1020. We understand the overall intent of this bill, but have significant concerns as to how it impacts hospitals. First, this bill does not address the underlying problem with workforce shortages. Hospitals across the nation, as well as in Maryland, have seen significant staffing vacancies, as high as 12% for registered nurses and 37% for LPNs. Hospitals are severely understaffed and need flexibility to ensure prompt and proper care and quality health outcomes for their patients. Moreover, staffing mandates or staffing mandated plans limit the flexibility as mentioned and create additional challenges for hospitals without resolving the workforce shortage crisis. Also, this bill in effect will exacerbate hospital throughput issues. It's been well documented that Maryland has some of the longest ED wait times in the nation. We appreciate the support of this committee as well as other committees as far as hospital throughput efforts. If these mandates or these plans are in effect, hospitals will experience bottlenecking in which patients are unable to be transferred into unit based off their conditions. Patients that are unable to be properly placed then lead to ED overcrowding and delayed hospital throughput for other patients. We have a panel of witnesses today that will discuss this issue in further detail, and for the aforementioned reasons, we urge an unfavorable report on Senate Bill 1020. Thank you.
Hello, Madam Chair, Senate Committee, thank you for the opportunity to speak with you today about Senate Bill 1020. My name is Mandy Bounds. I'm the Chief Nursing Officer at Atlantic General Hospital, Independent Community Hospital in Berlin, Maryland. Speaking without support for this bill just because of the significant workforce challenges that we currently face. We do not believe that this will solve our workforce challenges. Significant RN vacancies still remain in the direct care space of our acute care hospitals across the state. Myself and my colleagues across the state have worked to bring LPNs back into the acute care arena. We continue to experience significant LPN vacancies as well. There's a supply issue that we are working not only daily, but long-term in the profession to solve with innovative strategies. Daily, we're working on facing our challenges to take care of our patients, and we try to make the best decision for our patients and use our resources effectively. A bill like this would limit our ability to flexibly make those decisions. It would box us into rigid guidelines, and it also limits the innovation in the acute care space. We're working on different models of care with extenders, apprenticeship programs. We're looking at virtual nursing platforms to support our direct care nurses, AI, robotics, all those things help support the direct care nurse. They're actually innovative solutions to help our frontline teams. And for all those reasons, that's why I'm not in support of the bill. Thank you.
Good afternoon. My name is Kayla Wallace. I just want to take this opportunity to thank you for allowing me here today. I'm a nurse manager at a rural community hospital in Berlin, Maryland. Many of you may be familiar with Ocean City. As you know, our county typically sits at a population around 50,000. However, come Memorial Day, the beaches are flocked and our census peaks at around 400,000. Our hospital is small but mighty, and we provide excellent patient care, even in the midst of our population outgrowing our square footage. Our emergency department is one of the top performing emergency departments in the state of Maryland for throughput. A rigid clinical staffing plan would almost guarantee that during these summer months, our emergency department wait times and borders would increase exponentially. Research shows that mortality increases with every hour that a patient sits in an emergency department waiting for an inpatient bed. This is not the best choice for our community, for our patients, or for our nurses' well-being. Many hospitals have moved to an alternative care model to relieve the burden of lacking human resources. The answer is not to implement a rigid clinical staffing plan. The answer is the flexibility of innovation. The climate of healthcare in its current state calls for innovation, flexibility, and resilience to rapid change. We cannot limit our ability to be innovative in our care models when many of us are suffering from vacancy rates greater than 20%. We are strong supporters of shared decision-making, shared governance, nurse empowerment, and excellence in patient care. A rigid clinical staffing plan will not allow us to achieve these goals. Thank you for your time.
Good afternoon, Madam Chair and members of the committee. I'm here to testify in opposition of SB 1020, the Safe Staffing Act of 2024. My name is Stacy Mann, and I am the administrator for the Johns Hopkins Children's Center at the Johns Hopkins Hospital. In my role as administrator, I work very closely with my pediatric nursing and ancillary colleagues to ensure that we can provide adequate staffing necessary to care for the most critical and pediatric patients in the state of Maryland. While well-intended, this bill as written does not solve our underlying workforce shortages. Since the pandemic, hospitals across the country and state, including Johns Hopkins, have experienced clinical staffing shortages at times as high as 40%. Hospitals solved these challenges by implementing innovative solutions like you heard today, apprenticeships, the use of clinical technicians as nurse extenders, along with virtual nursing to assist in keeping our beds open. SB 1020 does not allow for us to continue to do that. We currently use national benchmarking standards to establish best practice staffing ratios with our nursing and ancillary departments. These standards are an excellent guide, but currently hospitals are allowed the flexibility to staff up and down in real time as needed based on acuity to meet patient care demands. This bill would limit our ability to do this while still complying with the clinical staffing plans established. The Safe Staffing Act would require us to reduce capacity if staffing ratios are not met daily, further exacerbating throughput challenges and access to beds for Maryland pediatric patients who need them.
For all of these reasons, I have mentioned Johns Hopkins and the MHA request an unfavorable report on SB 1020. Thank you.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I'm Lynn Marie Verzino, and I am the Chief Nursing Officer across MedStar Health. Each day in acute care hospitals across Maryland, nurses use their clinical expertise to meet the rapidly changing patient care dynamics and assemble necessary care teams. I appreciate the opportunity to share my concerns with the committee regarding Senate Bill 1020. SB 1020 challenges hospitals to meet patient care demand, inhibits patient access, and delays patient care. Patient flow changes day to day and minute to minute, as does the patient acuity. Our hospitals continue to go above and beyond to meet patient care needs when the nature of the care is unpredictable in advance. Each day brings changes in patient volume. SB 1020 prohibits the ability of our clinical experts to flexibly address staffing to meet ever-changing patient acuity. And I urge the committee for an unfavorable report on SB 1020 as it places barriers on patient access and does not support the staffing needs to flexibly address patient acuity and volume demands. Thank you very much.
Good afternoon. I'm Kim Elliott, Chief Nursing Officer at Holy Cross Germantown Hospital. I represent Holy Cross Health here today. Thank you for inviting us. I would like to echo everything that my colleagues have said. What concerns me most about this bill is that it is in direct competition with the EDDI project that has been created by the state of Maryland. If we implement this bill as it stands right now, it will limit the ability for me to admit patients because beds will have to be closed, which means patients will be waiting without care. Thank you.
Thank you, Madam Chairman. Peggy Townsend on behalf of the Maryland Hospital Association, also in opposition to this bill. We certainly support the intent and certainly support delivering quality health outcomes. I think that everyone can agree on that, but this bill is not going to get us there. As you've heard, patient flow changes day by day, hour by hour, and minute by minute. The clinicians need the flexibility to adjust to those changes. Another aspect where you need flexibility is all nurses are not equal. A new grad is not equivalent to a 30-year bedside nurse. And you need to be able to make adjustments for those kind of dynamics as well. Again, it's not solving the underlying problem. And for those reasons, we ask for an unfavorable.
Thank you. Senator Lamb?
Yeah, thank you, Madam Chair. Just to, I guess, follow up on the first panel, the question I had for the first panel. The bill sets up a process, right? And it sets up committees and whatnot. And it looks like there's even kind of an out in the bill because the head of a hospital can reject a plan that's being outlined. So why is there so much animosity to just setting up a process for there to be a discussion and plans on this?
I would note, I count, well, first of all, that provision is out of the bill because the amendments, are you proposing the amendments from the House?
You don't get to ask the questions.
Oh, I'm sorry, I apologize. So the amendments that the House has got the bill and substituted with a much simpler bill. So I don't know which one I'm talking to, but under the amendments that they offered over there, there's a whole bunch of shalls. And the way I read it, that requires the hospital to adopt these. And if you vary from it, you're in violation. It's not just a process. And then I think I heard the sponsor say there was going to be penalties. So that is even more concerning if every time we have to make a variance to adjust to patient acuity or clinical availability, we could be penalized.
Okay, well,
We haven't seen those
Yeah, we haven't.
amendments from the House bill yet. I don't think they've actually passed the bill out, so it hasn't come over. But thank you for those comments, and we'll certainly be looking at that. Another question, Senator?
Just one quick follow-up, because I agree. I was only looking at the Senate version, so I didn't have that House version to look at. My understanding is that some of the hospitals within that are members within MHA already have committees set up, maybe like University of Maryland Medical System and such. And so, you know, if they've been able to make it work, why can't all the other hospitals make it work?
I think most hospitals already do this, quite honestly. It's a best practice. But this is a mandate. And when it's a best practice, you can do variations if you need to.
Yes, so,
No, one person answers. I'm sorry.
apologize.
Are we finished, Senator? Thank you all very much for your testimony. I have one more virtual witness, favorable Janine Gonzalez. I probably said the name wrong. Hi.
No, you said it perfect. Thank you. My name is Janine Gonzalez. Can you guys hear me? Hello?
We can hear you. Go ahead.
Okay. My name is Janine Gonzalez. I have been a nurse for 35 years in New York. As a healthcare worker who is part of a clinical staffing committee, I am testifying in support of SB 1020. In 2019, New York passed the Safe Staffing Committee's legislation, and since then, healthcare workers have been key voices in tangible and effective solutions to staffing issues in the hospital. Before this legislation, I was like many healthcare workers in Maryland and in the nation, working understaffed, burnt out, disappointed by the inadequate care patients were receiving due to hospital management decisions on staffing, and left out the discussions to address healthcare worker crisis. SB 1020 gives workers a transparent process to come up with strategies and solutions named by workers who know the issue personally. Our clinical staffing committees meet monthly to report back on staffing conditions, complaints, issues, and we work together to find solutions. It's not just about staffing ratios, but about addressing issues that certain positions might have due to their assignments and unit protocols. The staffing committees hold all stakeholders accountable to make a meaningful change that truly can impact and improve the care we deliver. This legislation will foster true collaboration between hospital management and healthcare workers. I feel more empowered and happier in my position by being part of the staffing committee, because I know that my perspective is considered to help create better jobs for my coworkers and better care for my patient. With Maryland's all-payer model, it is poised perfectly to adopt the Safe Staffing Act of 2024 and connect staffing to quality care. I urge this committee to issue a favorable report.
Thank you very much for your testimony. Do I have any questions for this witness? I see no questions. That ends the hearing on this bill. And our final bill of the day and our final bill hearing of Senate bills of the session is Senate Bill 1060. Senator Ellis. I have your panel as David Pendleton, Brittany Garris, Tom Cahill, and Larry Casecamp. Larry, how many years have we worked on this?
Too many.
Can begin.
Yeah, thank you, Madam Chair and members of the Finance Committee and Vice Chair. Senator Arthur Ellis from District 28 presented Senate Bill 1060. In the interest of time, I'll cut my 6-page testimony down to 2 pages summary. It's on the system for you to see if you're interested. And I just want to say, since they've been here so often on this bill, let's just pass it this time.
Or is that your testimony?
Almost.
Okay.
So that was tongue in cheek. So I'm glad. Okay. So the question is, we have these long trains rolling through Maryland, and we've seen on the news and the effects of derailment around the country, and it's just really terrible situations. So number one provision of this bill is a 2-person crew on the train, one in front, one in back. Number 2, specify requirements when transporting hazardous material via freight trains. Let us know what's going on those freight trains. Number 3, specify requirements regarding wayside detector systems. Systems on the tracks tell us what's going on. Number 4, allow authorized railroad union representatives on railroad property for safety inspections. Inspections will help prevent accidents. Number 5, prohibit trains from blocking road crossings more than 5 minutes. And number 6 provision of this bill, prohibit railroads from operating freight trains exceeding 8,500 feet. That's around 1.5 miles. Currently, some trains extend up to 3 miles. And so very much a problem. So my truncated testimony committee members ask a favorable report on Senate Bill 1060.
So we're going to start with, are you David?
Yes, ma'am.
We're going to start with David and we're going to go right down the row.
Thank you, Madam Chairman. Good afternoon, Madam Chair, members of the committee. My name is David Pendleton. I'm a 20-year railroad employee currently working as a conductor. I serve as the Assistant Director of the Maryland State Legislative Board of the Transportation Division of SMART. Our members work as employees for CSX Transportation, Norfolk Southern, Canton Railroad, Alstom, and Amtrak. I'm here urging a favorable report on SB 1060, the Maryland Railway Safety Act. It is an all-encompassing safety bill meant to address several critical safety issues in the rail industry. There are incidents of Americans who have died while waiting on an ambulance because a freight train was blocking a road crossing. 3-month-old infant K-Twan Franklin died because paramedics were delayed 30 minutes by a freight train blocking a rail crossing. We have seen children having to climb over, under, and through live trains to get to school because of freight trains blocking rail crossings. On March 4th, 1996, in Weyerwago, Wisconsin, the town had to be evacuated due to a train derailment of 30 freight cars containing hazardous materials. Firefighters bravely rushed into danger to attack the ensuing fire. Initially, they didn't know the fire contained hazardous materials. The fire burned for over 2 weeks. Passage of this bill will require a reporting system be in place that is accessible to the state's emergency management agency and first responders. The cause of the derailment was a piece of broken rail in the switch that the train was operating over. Maryland has over 2,000 miles of railroad trackage, with only one state inspector qualified to perform rail inspections. Railroads in Maryland do not allow union representatives to perform safety inspections or investigate member safety concerns on railroad property. This company policy prevents the state from having trained, readily available supplemental inspectors that could identify these types of rail safety issues at no cost to the state. The conductor served as a first responder and incident commander before the fire department and emergency services arrived on scene. He prevented a greater tragedy by separating the non-derailed cars from the fire-engulfed derailed cars. Following the accident, Wisconsin passed their 2-person crew requirement in the law. Passage of this bill will require a minimum crew size, the reporting of freight train contents, supplemental inspectors, and a prohibition of excessive time blocking crossings. We sincerely urge a favorable report on SB 1060.
Okay, next.
Good afternoon, Madam Vice Chair, members of the committee. My name is Brittany Garris. I'm employed as a railroad conductor, currently working out of Washington Terminal. I'm here in strong support of SB 1060, or Maryland Railway Safety Act of 2024. I want to remind the committee of a very tragic accident that occurred in a small town of Lac-Mégantic, Canada. A Maine and Atlantic Railway crew member working alone had his 73-car crude oil train roll away and crash in the middle of a town, causing horrific death and devastation. When the crude oil cars derailed, they exploded, catching fire, flooded the downtown with flaming oil fires 3 times the height of the downtown buildings. 47 people lost their lives. More than 30 buildings were destroyed. 36 of the remaining 39 buildings in the town had to be demolished due to petroleum contamination. There are many tasks that must be performed by crew members on a freight train that one person just cannot accomplish alone. And this fact played a major role in this tragedy. Following this tragic accident, Canada banned single-person operations on these freight trains. The Obama administration instituted a rulemaking process to regulate crew size in freight rail industry. The Trump administration canceled that rulemaking process. The Biden administration has reinstituted it. However, this process has been in the making for over 12 years with no final rule. I would urge this committee to give SB 1060 a favorable report. Thank you for your time.
Next.
Good afternoon, Madam Chair and members of the committee. My name is Tom Cahill. I'm a 28-year employee of CSX, currently working as a locomotive engineer out of Baltimore. CSX's moniker is safety first. We believe this should be the policy and goal of the entire rail industry. With that policy and goal in mind, I'm here urging a favorable report on SB 1060. I'd like to highlight a railroad accident that occurred in East Palestine, Ohio. On February 3rd, 2023, a 151-car Norfolk Southern freight train carrying a large quantity of hazardous materials derailed in East Palestine because of a burnt journal bearing. 38 cars derailed, many of them carrying hazardous materials. 5 contained vinyl chloride, a highly flammable toxin, which caught fire and spewed toxic chemicals into the air that forced residents to be evacuated for over a 2-mile area. A year later, and over $1.2 billion spent for cleanup efforts, and some people are still not back in their homes. Following this accident, Ohio passed their state rail safety legislation, which includes a 2-person crew requirement and some provisions of SB 1060. The bill's purpose is to establish a state-mandated minimum threshold of requirements that hold railroads to the highest and most modern methods of monitoring freight trains that move through our communities and towns, and has additional provisions to limit train lengths and prevent block crossings. The proposed bill will require railroads to employ closer spacing and utilize the most state-of-the-art wayside detection systems to monitor multiple aspects of freight trains and ensure that railroad employees are properly trained on how to respond to alerts from wayside detectors and evaluate their findings in the field. Railroads will also employ the most current methods of tracking, wherein their wayside detector systems would monitor a train as it traveled over multiple detectors, measuring bearing temperature readings against prior detectors to alert train crews of potential rising readings or recurring axles that could signal a hot or burnt journal. These proposed regulations are of paramount importance to ensure the safe movement of trains in our state and protect our citizens and environment. I urge a favorable report on SB 1060.
Good afternoon, Madam Chair, members of the committee. For the record, Larry Casey Camp. I'm the State Legislative Director for Transportation Division of the International Association of Sheet Metal, Air, Rail, and Transportation Workers, here in support of Senate Bill 1060. I hope the committee recognizes the pattern as presented by the previous witnesses. That is, each one of these tragic accidents highlighted were followed up by legislative action by the location's legislative body, each one passing rail safety legislation, including two-person crew laws, to prevent these accidents from occurring in the future. But what Senate Bill 1060 is trying to do is to get Maryland to be proactive and prevent these types of accidents before they happen. What you have before you today, again, is the minimum two-person crew on freight train provision that passed this committee 4 times and passed the General Assembly twice, only to be vetoed each time by the previous governor. There are 5 additional provisions related to the safe operation of railroads. You have my written testimony, so with time constraints, I won't go into that detail. I would point out that since the two-person crew legislation was introduced in Maryland, it's become law or regulation in 10 additional states, bringing the total to 12 states having a two-person crew law on their books. It was law in Wisconsin and West Virginia before the efforts in Maryland. It has since been enacted in Arizona, California, Colorado, Illinois, Kansas, Minnesota, New York, Nevada, Ohio, Washington, and also just passed the Virginia General Assembly. The Republican and Democrat U.S. Senators from Ohio have jointly introduced the Federal Railway Safety Act, which contains many of the provisions in Senate Bill 1060, but is yet to be addressed by Congress. Maryland should not wait for the federal government to act. The country is headed in the right direction through passage of state laws regarding rail safety, and hopefully Maryland will get on board and join the ranks. We urge a favorable report on Senate Bill 1060.
Yes, Senator Lamb.
Thank you, Madam Vice Chair. Just a follow-up question, because I know some of the opposition have met with me and they've cited the fact that they do have plans to let emergency vehicles and emergency services through at some of these crossings or block crossings. Can you explain why you think that that's insufficient and what those risks, what risks are still posed by that?
You want to address it,
Tom? There are provisions in place. The conductors of the trains do carry specific detailed documents with them whenever we haul hazardous material out there, but we can always do better. We can do better with the use of electronic means that a responding fire department company, first responders could have that information available to them, just as they have the location of the accident available. They could be reviewing what that train is hauling, where it is in the train, where it is in relation to where the train has derailed or there's a potential problem, and just go into that scenario as best possible prepared as they could.
Okay, thank you. And important to note, I guess it sounds like 12 other states have moved forward with the two-person.
Yes, it's just common sense legislation.
Okay, any other questions? Oh, I'm sorry, Senator, were you finished? You're finished. Any other questions? Seeing none, we'll go to the next opponents or the opponents. Thomas Thompson, Aaron Martino, Lydia McPherson, and Brian Hammock. And just whoever sits, Tommy, just go right down that way.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Thomas Thompson on behalf of Norfolk Southern. To keep your legislative trains running on time, I'll simply say that this bill is preempted by 4 distinct laws at the federal level, and so your committee council has them It's the Regional Rail Reorganization Act, known as the 3R Act. It's the Interstate Commerce Commission Termination Act of 1995. It's the Hazardous Materials Transportation Act of 1974 and the Federal Railroad Safety Act. Those all preempt all the provisions in this bill. I'd ask for an unfavorable report. Thank you.
Thank you. Next.
Hi, my name is Lydia McPherson. I'm the Regional Government Relations Manager for Norfolk Southern. I too will try to keep it very short. You guys all have my written testimony, but I do just want to take this time to highlight the role that the federal government already plays in regulating rail. First off, hazmat reporting. We actually already submit very comprehensive reports to every state that we operate in that gives very detailed information about what kind of hazmat we carry through the state. And that's on top of an app we have called Ask Girl, which I'm happy to answer questions about, that gives real-time data about what's on any given rail car. So happy to answer questions on that, but that's something that we are already addressing. Another thing is crew size, like the other witnesses said. That's something the FRA has looked at for many years. And we're actually expecting a finalized rule to be announced hopefully sometime in March. In its notice of opposed rulemaking, the FRA actually cites the need to avoid various state laws from creating a patchwork of regulations throughout the country, noting that, quote, such a patchwork of state laws would likely result in significant cost and operational inefficiencies and even potential safety concerns from a lack of a uniform standard. That can be applied to many other aspects of rail operation, including wayside detection systems, which are very complex systems, and I'm happy to kind of go into the logic behind that. But for now, I'll yield my time and happy to answer questions.
Good afternoon, Aaron Tramarchio with Trade Point Atlantic. I think the committee is familiar with Trade Point and what we've been doing over the last 10 years. We do own and operate a short line railroad, and we have a planned Sparrows Point Container Terminal project, $1 billion investment that will create 1,100 new maritime jobs for the Baltimore region. We're concerned with this bill. My testimony lays out some of the specific concerns that we have, and we think that this bill puts that project at risk and nullifies the investments that the state and the federal government are making in the Howard Street Tunnel to make railroading through Maryland more efficient. Thank you.
Okay, thank you. And Brian?
Madam Chair, Brian Hammock for CSX Transportation. I'll just point out a few things in the testimony that you have. In the fiscal note on page 7, it states that TTF expenditures may further increase significantly by at least 18.4 million to 23.2 million annually, including a more than $1 million annual cost to the state-owned Canton Railroad Company. Also want to point out in the testimony from Ports America Chesapeake, Ports America is the operator of the state-owned terminal at Seagirt Marine Terminal. And they say that this bill poses a significant risk to the efficiency and competitiveness of the Port of Baltimore. I know many of you are familiar with the port and have been out to the port. It's a complex ecosystem, and rail plays an integral part of that. It's the arteries of the heart of our economy. And I just, respectfully ask the committee to have caution when creating an entire new regulatory environment around something that's already heavily regulated at the federal government. Thank you.
Do I have questions, Senator Ellis?
It's not a question, Madam Chair. I just want to recognize little Mr. Brian Hammock. He's in the back right there. Could you stand up and wave to everyone, please? Yeah.
Madam Chair, this is my son, Leo Hammock. He's 8 years old. Today's his 8th birthday, and he said he went to come see the Senate of Maryland.
Happy birthday, Brian.
And he's 8. He has not seen a year where Maryland has not considered a 2-person crew mandate.
I have not seen a year either. Thank you. Do I have any, Senator Lamb?
Happy birthday, Brian. Just one quick question, because I know that obviously this bill's come up a few years, but my recollection is that in 2015, I think Senator McCray has a letter from the AG that suggested we're not preempted on a 2-person crew bill. So can you kind of explain why you still have concerns about preemption when we have a letter from our own Attorney General saying that that's not a concern?
Sure. I don't have concerns about it. I have the utmost confidence as an attorney that preemption exists with regards to this. We saw this bill passed in Illinois, the most recent iteration of 2-man crew. That when the courts got it at the federal level, their direct quote was, "It's too specific to ignore the preemption in this case under the 3R Act. Maryland falls directly under the 3R Act when we reorganize Conrail. So the most recent case law on this directly on point says it's too specific to ignore the preemption with regards to two-man crew on this issue. Now, I think this committee can rest assured two-man crew is going to be put to rest this March when the federal government finally ends their rulemaking. They asked for a limited extension, which they received, and the Federal Rail Administration is going to put this issue thankfully to bed because I agree we've been debating this now for way too long.
Okay, thank you.
Thank you. I don't see any other questions for this committee. Thank you. Thank you all for being here. We have one virtual unfavorable, Paul Barnes.
Thank you, Madam Chair and committee members, and most importantly, happy birthday to Brian. My name is Paul Barnes. I'm president and CEO of the Canton Railroad. We are a small Class 3 short line that serves customers in the Port of Baltimore area since 1906. And I am urging you to oppose SB 1060. In the interest of time, I'll touch on three of the aspects that most directly impact the Canton Railroad. First is the two-person crew. Specifically, a two-person crew requirement would add considerable time and cost to our operation. Based on previous studies and my own professional observations riding with locomotive crews, multiple crew members in a locomotive cab could create distractions, impeding safety and productivity. My personal observations, my previous job with another railroad, I rode locomotive crew members, and some of those were one-person crews and others were two-person crews. The one-person crew tended to be much more focused and vigilant on the right-of-way and the task at hand. Moving on to the hazmat database, the Canton Railroad operates safely and has not had an incident involving hazardous materials since 2007. We train our employees on a regular basis to ensure safe operations. We coordinate with first responders to ensure they are informed of the hazmat commodities our railroad moves, and we offer training to educate responders and employees on how to handle any releases. Accordingly, the need for a state-operated hazardous material railroad database is not needed. And the question also comes up about the cybersecurity issues with that database if it's compromised. The third aspect is union inspections. The provision for railroads to allow union representatives to investigate railroad operations is very problematic and redundant. The Federal Railroad Administration, or the FRA, inspects our operation on a regular, usually unannounced basis. The FRA are experts in the inspection field, labor unions are not. Our operation is extremely cost sensitive, particularly since we compete with over-the-road truck on price and service each and every day. Additionally, we need to continue the great strides made in recent years to make our port more competitive, not to go in the other direction. For these reasons, I ask that you oppose SB 1060. Thank you for your time.
Thank you for your testimony, Mr. Barnes. Any questions for Mr. Barnes? No questions. That ends the hearing on Senate Bill 1060. Thank you. As soon as Tammy gets this switched over, we're going to start voting.